Oh, I don't know as many.
Good morning again.
It's gonna be fast.
I'm the late June doll. I didn't make it here yesterday. It was an interesting day, but I lived through it. I just want to, as someone from out of town, tell you how exciting all of this is. And if you didn't see today's Missoulian, you really need to find the article on the front page. As Dr. Fishman said, he couldn't have done better if he'd written it. It's experts: untreated pain as serious as drug abuse. So a great message was conveyed from this meeting yesterday and continues today. I'm subbing for someone. I guess that is appropriate since Dr. Gruden was so gracious as to sub for me yesterday. So we have a panel to discuss challenges in prescribing opioids and possible solutions. I think we all know that there are gazillion challenges, so it'll be wonderful to hear the solutions. Our first speaker is Mark Long, Narcotics Bureau Chief, Montana Department of Justice, Division of Criminal Investigation in Helena. He's been actively involved in research, policy, statute drafting, and committee presentations during the past 4 state legislative sessions. The Montana legislature has really been active, and we're very pleased about that. Mr. Monda.
We go from there.
You can do it from there, I guess. Either way. Go ahead.
Everyone hear me okay? Is this thing working? Okay.
Oh, towards you. There you go.
How's that?
Is there an on button?
That one is, isn't it? How about this one? All right. Okay, well, thanks for having me here. Any other law enforcement in the room? I want to start out right off the bat reiterating the fact that I'm with the Montana Department of Justice, as opposed to the Federal Department of Justice. They are represented here, but it's not I. My involvement in drug enforcement in Montana has been over the course of 20 years in drug enforcement, and then law enforcement 30 years. You know, and each decade seemed to have its drug of problem for us. In the 80s when I started, it was cocaine. Of course, everybody knows in the past 10 years or so it's been methamphetamine. In the last couple of years, well, probably for the last 10 years while we were dealing with methamphetamine, this particular issue was out there as well. Most of us in law enforcement at the state and local level were so focused on methamphetamine that we didn't have a chance to really pay attention to this until we were way behind the curve on it. Probably only a year ago did this particular issue come to my attention, and I started to do some research into it to see how big a problem it was, and I was just shocked at the numbers. I could have brought some PowerPoint graphs along to show the increase in some of the problems associated with these drugs. They all look the same, so if you just picture that screen over there with the graph starting in this corner down here, it goes up to that corner up there. That's the way all the slides look. Except for methamphetamine deaths, and they go up and they top off and they come down, which I guess is a good thing. In my research into a little bit about what the problem is in the state, I started trying and find some data on these prescription drug-related deaths. And some of the statistics, the crime lab was a great place to go for that, and we captured the unattended deaths there. That's all. And that was enough for me. I didn't look into it any further. Unattended deaths due to the top 20 prescription drugs have averaged over the last 8 or 9 years about 250 people in Montana. And again, that's just the unattended deaths, so I'm assuming that's probably a lowball number. But that was enough to get my attention. Since that time, we as an agency, the Department of Justice, Division of Criminal Investigation, started making this a little bit more of a priority. Not surprisingly, when we did that, our caseload, our percentage of this type of cases, as a percentage of our overall cases, went from an average of about 5 to 6% of our cases a year up to about 60. About 60% of our cases this year are felony cases of distribution, illegal distribution of these drugs that we've been talking about today. Those cases that we're working, again, I need to, and this is not to jam on Paul here from DEA, there is a distinct difference in our missions between state and local law enforcement and federal law enforcement. Paul will talk about what his agency does and what their goals, objectives, and parameters are, and I'll talk about state and local. From our point of view, what we're doing, exclusively at this point, all of our cases are felony illegal distribution of these drugs that you people are talking about. I'm aware of the statistics that I think Dr. Fisher talked about, where 99% of the prescribing of these drugs is all legitimate. That does not surprise me a bit. But somehow those legitimate prescriptions and those legitimate drugs are making it out to the street and they're killing people. And that's what local law enforcement has to deal with. We are buying these particular drugs that you're talking about illegally, probably hourly. We bought 350 Loratabs last night in a bathroom in a bar. And we'd be buying them today, except I'm the only one in our agency that doesn't have the day off. But we'd be buying them today. We're buying them, like I say, 4 or 5 times a day somewhere in the state. We're buying these drugs. Where they're coming from, I mean, you can only imagine. A large portion of them are stolen. They're stolen either by family members. Sadly, there's a lot of them stolen from legitimate sources by healthcare workers. I just use it general like that to not single out any one particular group. The variety of the medications we're talking about are as varied as those are that you prescribe. Obviously, hydros and oxys are the main ones. We're seeing a lot of fentanyl, the fentanyl patches and the little lollipop things, but a lot of fentanyl patches. It's real common for people to get their hands on those because I know there's a lot of guidelines and policies in place that are supposed to work to take these used ones off the street. Perhaps they're not always being adhered to. A lot of healthcare workers or people that are in those facilities are finding them in garbage cans. Sadly, they'll peel them off the patients. There have been some cases where they pull them right out of the dirty needle boxes. Take them home, chew them up, knead them, cut them into chiclets, knead them, boil them up, drink them in tea, and there's other ways that they can administer this stuff into their system that I don't want to talk about right before lunch. Now, within the last couple of weeks, there have been some cases where the little morphine jars have been found that had the tops removed, the morphine removed, replaced with something else, the tops were glued back on, stuck back in medicine or narcotics lockers. It's a whole variety of things, and probably this audience here knows more of these anecdotal situations than I do. Those are just some that we're dealing with. My point here being that, and a couple other scams, I mean, a lot of this stuff comes from legitimate patients, all right? People that you are prescribing to legitimately, they take the medicine home, put it in their cabinet, their kids steal it, their friends' kids steal it. There's an area of the state where it's pretty common for children to go out with their parents on Sunday afternoons to the parade of home things, the real estate things. And, hey, can I use your bathroom while I'm in looking for pretty home? Sure, go ahead, it's down the hall, second door on the left. Same place their medicine cabinet is. There have been cases in the state where, I hate to even name the organization, but it's an organization of kids that go around and sell cookies at your door. And while they're there, they need to use your bathroom. Just some things like that. That's our issue, and the fact that there's a couple hundred people dying from this every year. Now, I'm not here to say, obviously I'm not going in front of this crowd, but I don't in front of any crowds profess to have any idea what you do is correct or not. I assume that it is. But what I'm saying is when we, as we did last week, meet a patient in the parking lot of the pharmacy on the day they fill their prescription and they walk right out of the pharmacy, bag's still sealed, and they sell that to us in its entirety, there's something wrong with the system. Even I, as a dumb cop at that point, would suggest that perhaps there's some overprescribing going on there, and I don't blame any of you for it, but there's something going on. We bought 60 Lortabs the other day from a lady, and she said, you can have my next 60 next month when I get them. And the undercover agent said, well, have you ever even had like an exam first? Oh yeah, well, I had a good exam. Okay, well, when was that? 2.5 years ago. You had one since? Well, no, I just been getting her Lortab refilled for 2.5 years and selling them right. And it's not like these people are getting the prescription for 100 and they're keeping 80, saying, I gotta have these 80 from my pain, I'm gonna sell you the other 20. They're selling the whole works. And a lot of times they're paying, well, you know what the prices of these are better than I do, but they're selling them for, you know, $1 a milligram when they hit the street, so, or more. Okay. That's what kind of got me into this, and then I started realizing that law enforcement as a whole, well, by the show of hands of how many were law enforcement here, you can see that our participation in these discussions are somewhat limited, and I just felt at some point here that we needed to get a little more involved. You had your issue with it, I've heard some of that this morning. We have our issues with it, you've heard some of that this morning. Somewhere in here, there's got to be some common ground. One of those things that I think will help immensely is the prescription monitoring program. Starla here is going to talk about that. I'm not going to, other than to probably try to dissuade some myths, urban legends, misconceptions that are out there in your community as far as what law enforcement, state and local law enforcement will use that tool for. I believe the way, and I'm not going to get into her 20 minutes here, but I believe the way this is going to shape up is that this program will be monitored and operated by the Board of Pharmacy. It's not going to be operated by law enforcement. We are going to have, if we have any access to the system, it's going to be extremely limited. Just the way it's shaping up, I cannot really foresee that this is going to be much of a valuable tool for law enforcement. It's going to be a hugely valuable tool for addressing this problem, but I think it's going to be an industry kind of a policing thing for y'all. I don't know that law enforcement is going to have much access to this, therefore it's not going to be much of a tool for law enforcement. There's not going to be any possibility that we can sit around on all of our downtime and fish through this system and try to find people to go after. We've got more than enough of that comes through our door every day. We don't have to go look for it. I guess I'm not going to cover this too much more. Actually, I think the Attorney General covered some of my material yesterday. Actually, the doctor did this morning with a lot of it too. He kind of covered some of the abuse problems with it. I guess kind of in closing, my advice here, while there have been some people here that don't seem to be able to grasp the concept, and I understand why, of what reasonable measures are. I realize that is a vague issue, but some of them that I've seen, and I saw a model policy up here, and I think it was from the state medical boards or
Federation of State Medical.
Federation of State Medical Boards, which listed a bunch of great guidelines. I think from the cases that we're making in this state, if you all were to follow that as best you can, it would pretty much eliminate this problem. Now I realize that I've been in law enforcement 30 years, and I realize in my career there are times when things get pretty hectic and it's hard to follow each and every letter of every single policy, and I know in some of your businesses it's the same way. But the vast majority of these cases that we're working, we track them back to somewhere where there's of the ones that are being stolen out of medical facilities, there's just a breakdown in your already existing policy. I was talking to a nurse the other day from a local hospital here, and she was explaining to me the policies and the procedures and the practices in place to monitor the dispensing of this medication. And that's like, I mean, that is probably 10 times what I thought was necessary to alleviate the diversion of this. But not all places are that way. I've been in hospitals. I won't even ask for a show of hands of how many you people have. Hospitals or clinics or any kind of a facility like that where there are narcotics lockers or whatever their place is to store their narcotics. has the key just stuck right in it because it's too hard to go track down the person that's got the key. It's a lot easier just to open it up. And I'm seeing some chuckling around here, so you all know that's going on. I think some things like that are reasonable measures. So I don't have any more on that. I'm going to turn the rest of it over to Paul Jasper. I guess there's a question and answer period at the end of this.
Yes, there is.
Okay, so we'll wait for him then.
Thank you very much. We'll now hear from Paul Jasper, diversion investigator of the Denver Field Division of Billings, the Drug Enforcement Administration. He's held this position for 20 years. He conducts administrative, civil, and criminal investigations involving DEA registrants, including illegal use of legitimately controlled substances. The floor is yours, sir.
All right. First of all, I'd just like to thank Kay for inviting me to come to speak here today. I looked over the entire symposium. It looks like there's a wide range of expertise in this room, and I wasn't able to attend yesterday, but it looks like a great program. I'm glad that law enforcement is here. I think it's important that people hear our perspective on the issue, even though I'm sure there's a lot of issues as far as how law enforcement interacts with these situations with patients and chronic pain and prescribing and all that. So it is important for us to speak. It's a very sensitive issue, as we all know. Pain issues are continuous. Pain management is a very important topic. But DEA's perspective is primarily to prevent the diversion if possible. Our mission is basically to have a closed system of distribution. We try to track the controlled substances from the manufacturing level all the way to the street level to the end user. That is a complicated process. I'll give you a brief history of the Controlled Substance Act. It was formed in 1970. It was basically designed to comply with international treaties. There's quotas involved with raw materials coming from foreign countries, how much controlled substance can be manufactured on an annual basis. We enforce all the regulations out of the Code of Federal Regulations, Part 1300 to the end. I'll discuss some of those regulations today. It might help some physicians or medical practitioners here that handle controlled substances. So if you do have some issues in your office, that maybe this would help bring your practice into compliance, prevent future problems. The mission of the Office of Diversion Control is basically to prevent, detect, and investigate the diversion of controlled substances from legitimate channels, while at the same time ensuring an adequate and uninterrupted supply for legitimate medical scientific purposes. I discussed earlier the Controlled Substance Act of 1970 was established as a system for United States compliance with international treaties. It serves as a legal foundation of the federal government's authority over controlled substances and listed chemicals. Consolidated over 50 laws regulating the manufacturing, distribution, import, export, and dispensing of controlled substances and listed chemicals. The closed system of distribution obviously begins at the raw material stage, where the controlled substance is actually in the process of manufactured into the final form. We have established schedules. Obviously, everyone probably knows the various schedules from 1 through 5, 1 being no legitimate medical purpose, and Schedule 2 being most highly abused, or most highly abused potential. Medical professionals that prescribe or dispense are required to have a DEA registration. Many of you are aware of that. It's a very important aspect of prescribing. We have seen physicians prescribe illegally without a DEA registration. Obviously, you don't want to do that. Record keeping requirements are very important if you handle controlled substances in the office. And I'll go through some of those regulations if you're not familiar with them. A lot of physicians don't, when we talk to them, they're not aware of some of these regulations, so it's important that you at least do a little bit of research if you're not familiar with the security and the inventory requirements. You can get on our website also, the DEA diversion website, and you can go through that, and some of the regulations are on there, as well as the Code of Federal Regulations. There's over 1 million DEA registrants. This includes practitioners, mid-level practitioners, pharmacies, hospital clinics, manufacturers, distributors, researchers, dog handlers, analytical laboratories, importers, exporters, and narcotic treatment programs. In Montana, we don't have that many narcotic treatment programs. We have office-based opiate treatment programs where physicians are qualified or go through certain training to handle Suboxone and other agents associated with trying to detox people off opiates, which seems to be on the increase in Montana. Record keeping and security requirements, as I discussed before, are very important. All DEA registrants are required to maintain a complete and accurate record of all controlled substances handled. They're required to maintain security for the storage of controlled substances where applicable. There's various regulations associated with inventories. Every 2 years they should do a physical inventory of the controlled substances that they have in the office. If they handle Schedule II drugs, they should handle if they purchase them from wholesalers, they're required to fill out a DEA 222 order form, which can be ordered online. It's a triplicate form. They maintain the first copy, which is the supplier maintains the brown copy, which is copy number 1. And the blue copy is the second copy. They're required to maintain the receipt copy, dated and signed who received the controlled substances. And the third copy goes to our agency. Dispensing records are required if you do dispense controlled substances to patients in the office, which is very rare. We discourage it because a lot of times there's internal employee theft or diversion within the clinic. Administration is more common. Sometimes physicians will maintain a small amount of controlled substances for administration purposes. Record-keeping requirements requires an individual practitioner must maintain records of controlled substances which are dispensed other than prescribing or administering in the lawful course of practice. Requires the individual practitioners must maintain a record of controlled substances which are administered when the practitioner regularly engages in dispensing or administering lawful course of professional practice. Requires that individual practitioners must maintain records of narcotic controlled substances prescribed in the course of maintenance or detox treatment. The security requirements are required only when the practitioner stores controlled substances in his or her office for dispensing and administration. Individual practitioners must store controlled substances in Schedules 2 through 5 in a securely locked, substantially constructed cabinet. Some of our registrants that handle controlled drugs for like dog training purposes or other distributors require more stringent security. Sometimes it would involve maybe a safe that's bolted to a floor or a wall so it can't be removed. Limited access is something we also encourage. If you do maintain drugs in the office that are abused, keep limited access as far as what employees have keys or combinations to various security storage areas. As far as prescription requirements, in order for a prescription to be legal, it must be issued by a registered practitioner, has to be prescribed for a legitimate medical purpose, and be issued in the course of professional practice. And I know there's some question about what's reasonable, and I think that's been discussed already as far as DEA, like Dr. Fishman was saying. I believe that our agency is reasonable in terms of understanding that we're not doctors, that we're not going to tell physicians how to practice medicine, but we also try to inform them about other issues with regard to patients. We a lot of times don't share information based on the sensitivity of the investigations, and that's for the patient's protection as well as the physicians. The Controlled Substance Act and the Code of Federal Regulations basically explain everything that applies to controlled substance issues, regulations. The pain management issue seems to be a real important aspect now because of the street abuse and As far as DA's perspective, we want to make sure that the patients are treated according to whatever the physician believes is necessary for that patient. So we're not in the business of trying to practice medicine, obviously, but we do sometimes have contact with physicians based on what we're seeing as far as the pharmacy information, or if we see trends in certain areas with abuse. There's been legal standards established, talked about the history of the Controlled Substance Act. The drug trends that we see in Montana, I believe, are pretty common around the United States. Hydrocodone is one of the top abused drugs. I believe it's mainly because of the availability of it. It can be refilled, and on the street it has value. Most of the drug prices are up to $1 a milligram. That's pretty common. The internet has created a bigger problem for the DEA. In my experience, we have had some investigations involving internet pharmacies, internet doctors prescribing to patients. So I think that's one of the things that's really hurting society in terms of a larger scale problem that may not necessarily affect physicians or DEA registrants, but it does indirectly if you don't know the patient has other sources of controlled substances that you're not aware of. Some of the professional patients out there, what we call doctor shoppers, can be a very big problem for physicians or anyone who prescribes controlled drugs. They shop around. Sometimes we've had complaints recently regarding dentists who are on call after hours on weekends, and a person will call and get a hold of the on-call dentist, or any physician for that matter, when they're on call. Sometimes patients will scam the doctor who's on call and say, hey, I've been Dr. Jones or whoever the doctor is patient for 5 years, and I ran out of hydrocodone, and maybe the doctor for some reason doesn't have time or doesn't want to verify the information and goes ahead and calls in a prescription for the person. So that's one thing you want to watch out for. Early refills, patients that are constantly hounding the doctor for controlled substances. They said they got their dog ate it, or they lost it, or they can't find it, or excuses that they constantly give the doctor. You have to watch out for that as well. Suboxone, I believe, is something that's handled by the office-based opiate treatment programs. I've interviewed a lot of physicians who handle that, and they seem to have good success with that in these programs. But it also has street value. We're hearing more information that Suboxone is being sold on the street, and I'm not sure exactly why. There's a lot of theories on that. I don't really have much more to discuss. I kind of went through this pretty fast. There is a Washington Post article that came out recently regarding a study that was done by the National Center of Addiction and Substance Abuse at Columbia University. And they were asking the question of, is it easiest for somebody, mainly directed toward teenagers, and they were talking about how it's just as easy to get pills as it is any other drug. 19% of teenagers found it's easier to purchase prescription drugs than cigarettes, beer, marijuana, or compared to 13% a year ago. So the increase, it's gone up since last year as far as availability of prescription drugs. A quarter of the teens said it's easy to buy marijuana, with 43% of 17-year-olds saying that they could buy the drug in less than an hour. This study also found a large group of parents who don't know where their children are in the evening. It identified a group of problem parents who basically who resulted in the increase of abuse of illegal and prescription drugs among 12 to 17-year-olds. This chairman of the president of this center said there are basic steps that could avoid being a passive pusher, which I guess they're describing the parents. 34% of the teenagers abusing these drugs, like OxyContin and Vicodin, obtained them from home, from their parents. 50 years ago, this article said 50 years ago, people would lock up their liquor cabinet. Now they're talking about locking up the medicine cabinet. It just goes on to say parents aren't paying attention to their children. And if there are parents who are legitimately prescribed controlled substances, they should definitely have security for those controlled substances to avoid this. The access is, there's also been articles written about farming where kids will take the pharmaceuticals to a party, they'll put them in a big bowl or something, they'll just take whatever it is, they don't even know what they're taking. So it is a very serious problem, and we do have people from our headquarters that speak at these initiatives, but in this case I thought it was important for me to speak because I work in Montana, and I'm available in the Billings office. If I can't answer a lot of questions today, I'm more than willing to answer questions from the office as well. If you have specific questions that aren't answered today. But our agency definitely has an open perspective in terms of not taking appropriate action on, depending on the kind of investigation. I believe that in my experience in our agency, any action that's usually taken against the DA registrant is what we believe is appropriate. I don't know if I'm going to answer any questions now, or do we have time?
Paul has to leave at noon, so can I ask any questions there? But we're doing pretty good on time, so you have questions.
Because I can take a few. We got 3 or 4 minutes. 5 minutes. Okay.
Proverbial question you always get. What do you do when a patient comes to you after getting a prescription of narcotics and says, "Doc, here they are. They make me sick. Look at the rash. I don't want them." How do you dispense them? What do we do?
Actually, there's a new program that's, I believe, I'm not sure if Mark knows about it, it's just starting to come out there. There's a proposal now to have a take-back program where law enforcement agencies can accept these drugs so that the doctor doesn't have to take them back. And we don't accept them anymore. And I realize the position that physicians can get into with their patients. They don't want to end up on the street. But we can't, as an agency, based on the environment and all that, we can't tell someone how to destroy them. But security is important, and I don't think that DEA would take action against you for having possession of those if you have an inventory for those drugs and that you have appropriate measures of disposing of them that it's legal. But I would encourage physicians not to accept them because they're to the end user, and the end user is the patient. So it poses risks in both situations, I think. But this program, you can call me later and I can potentially get you some more information once the law enforcement agencies are initially involved in this program. Then that would be where the person would have to take it.
Our program in Wisconsin, we have a program whereby patients are encouraged to bring in the bottles. The bottles are, the contents, and it's a public health concern, but the contents are flushed by a healthcare professional, witnessed by another, witness consigned to the medical record. And that's what we've been told is what we have to do with these things. Wisconsin State Journal this morning, they do have a clean sweep program. It's a take-back program. They encourage people 3 times a year now to clean out their medicine cabinet of anything you don't use. Bring it. It will be collected by the government and incinerated.
Hi, I'm Dr. Richard Wise from Kalispell, and I've been prescribing Suboxone for about 3 or 4 years now. Just to answer your question over Suboxone use, number one, I'm getting near my maximum. We need other people to prescribe it, so I'll put in the pitch for people getting the next DEA number to prescribe Suboxone. And as far as abuse of Suboxone, I found that patients will sell it to other opiate addicts that run out of their Lortabs and Vicodins and Percocets because they're sick, they're friends, so they'll give Billy Suboxone, or sell Billy, sorry about that. They'll sell Billy a Suboxone for $20. I found that's the main abuse of Suboxone is selling it to other addicts.
A year ago, February, in Bethesda, under the sponsorship of your affiliate organization, NIDA, and NIH and NIMH, there was a conference and it was specifically directed to this problem. So a little over a year and a half ago, they presented data that I don't believe has changed at all. And at that 2-day conference, what they showed was that physician prescribing, and this is data prepared using your agency's information, was 14% of the available drugs diverted that resulted in morbidity or mortality. 14%. That conference stressed very heavily that it is an unknown factor, that both the internet, probably with some element of organized crime involvement, has the majority effect on this problem. So while there's no denying that there's been increased morbidity and mortality, the only thing we can do is if we stop writing controlled substances for every patient today, we'll lower the incidence of this problem by 14%. That's ridiculously small, and all it does is deny people legitimate medical care. And then the observation I want to make is that you stated that action in Montana is appropriate by your agency. Time Magazine did a very clear article on what happened to Richard Nelson in Billings, and they didn't think it was appropriate.
Paul, hi, I'm Eldon Matrea. Was there any response to that, or is that just...
Did you have a question about anything, or?
No, I think it's just making a comment.
Okay.
Okay, Paul, Eldon Matrea, PA from Great Falls, but I grew up on the Blackfeet Reservation. And the reservations, just from my personal experience, there's a lot of drug diversion. Do they report that to you? And if they do, is your agency the one in charge of law enforcement against that, prosecuting that? And how do you start?
Yeah,
communities, you're cluster crops, you're the same thing.
Yeah, we work with other agencies of Bureau of Indian Affairs, as well as tribal police, various other law enforcement agencies as far as Indian reservation investigations. But that's a whole nother area of problems in various states that have that issue. But we do work in conjunction with other law enforcement agencies, including the State Department of Criminal Investigation involved in those cases. But there's problems there too as well.
Craig Shannon, I'm a lawyer here in Missoula. Yesterday, Mr. McGrath talked about prescription drugs and how they're responsible for hundreds of deaths in just Montana. He didn't talk about the nation. And I'm wondering if you can tell us if you have the numbers from your data that reflect the number of deaths associated with the medical use of marijuana.
I don't have any data on that.
Are you aware of any deaths associated with the medical use of marijuana?
I don't have any data on that.
Are you aware of any?
I don't have any information about that. I wasn't prepared to talk about that issue. Our website might have some information, statistics. You can contact our headquarters regarding any statistics, or our policy and liaison section in Washington would probably have more up-to-date information on that.
You haven't been made aware of anything?
I don't have any data.
Thank you.
I'm sorry.
Thank you very much.
Mr. Jester. Tefford Olds, I'm a mid-level practitioner from Kalispell. We, under the DEA, can prescribe Schedule 2 through 5 narcotics, which have a high abuse potential. When we want to get these patients off of narcotics and switch them to Suboxone, mid-levels can't write Suboxone because they don't have an X license. Who sets the requirements for limiting X license to physicians, and why are physicians limited to 100 patients?
I'm not sure of the limit on patients. I know it was 30. I know they did increase it to 100, but as far as the Suboxone issue, I don't really have an answer for that.
Is it the DEA that sets that requirement?
No, not to my knowledge. But if you give me a call, I can get more detailed information for you from our headquarters.
Okay, we only have time for one more question.
Yeah.
Or unless it's very short.
Okay, in response to his question, there's been 0 deaths from medical marijuana. I hear a lot of doctors who their greatest fear is the DEA, that it's going to come after their license, yet the 2002 court case which set the example, and in 2003, the Supreme Court upheld that case, saying doctors unanimously have the right to recommend and discuss marijuana with their patients, and that they can't investigate or revoke the license of these doctors. Is this in true fact? Or, which if it's true, then doctors don't need to be scared anymore. Or is there something that I'm not aware of?
Well, as far as my responsibilities in the job that I do, I handle mostly investigations involving pharmaceutical drugs. So I believe if anybody has any other questions about the medical marijuana issues, you'd have to contact our DEA headquarters about that.
I think we have to move on.
Thank you very much. I appreciate your good questions.
Thank you very much for being here, and obviously people could ask you questions for another hour or two. It's incredibly important that members of law enforcement be present, members of regulatory agents be present, so that you can dialogue with one another. Because one of the big problems in our society has been lack of communication. So your presence here is very, very much appreciated. Now we will hear. Now we'll hear, I think, another person from California. Is that right? Two on this podium. Adam Wolf, the staff attorney with the American Civil Liberties Union Drug Law Reform Project, a division of the ACLU's National Legal Department. The project conducts the only national litigation program addressing the civil rights and civil liberties violations arising from national and local policies. Its goal is to end punitive drug policies that cause the widespread violation of constitutional and human rights, as well as unprecedented levels of incarceration. So now we'll hear a different perspective.
Good morning, and thanks for having me. It's a pleasure to be here. I was invited here to talk about civil liberties issues in pain management, or perhaps more simply, how America's drug policy affects pain management professionals and their patients. Now, note that I say drug policy and not the war on drugs, and I say that deliberately, because this is not a war on drugs. This is a war on people. It's a war on people who use drugs. It's even a war on people who believe that certain controlled substances can have a beneficial effect on people. That means students and teachers, the young and the elderly, the sick and the healthy, those in the privacy of their homes or those in public, and for present purposes, the physician and the patient. How does this play out? How does this so-called war waged on physicians and their patients? We see civil liberties violations, or at least concerns, in numerous aspects of the government's pain management policies, a few of which I'll mention here. And with all of them, the common theme is politics over science, political agendas replacing reasoned healthcare practices. I'm going to talk about three issues: prescription databases or registries, prosecutions of pain management doctors, and medical marijuana. Prescription registries and databases, there's been some talk of them here, and I think many of you actually have better knowledge of what some of the facts are on the ground about that. What I want to talk about are some of the civil liberties issues that arise with them. From a civil liberties perspective, there are bad registries and there are worse registries. The serious concerns of prescription databases vary, depending on who needs to respond to them, what information is asked, who may access the database, and how secure it is. But let me assume for present purposes that we're talking about the least egregious of these databases and why those are still untenable. The basic problem with registries is their intrusion into medical privacy. What medical condition somebody has, what medications they're taking for those conditions, those are private, and perhaps uniquely private matters. Listing names and dosages reveals to our government sensitive information. There was a time not long ago that this was among the most confidential information we had. We trusted that when our physician wrote out a prescription, this wouldn't be shared with anybody but the patient and the trusty pharmacist who dispensed that medication. And that's important for two reasons. The first is patient confidentiality. Patients have a significant privacy interest in not going public with their medical conditions, with not sharing their medical conditions and or the medications they're taking with their government. Whether one has cancer, AIDS, HIV, STIs, even heart disease or high blood pressure. That's something that you share as a patient with your physician and probably with your pharmacist if you need medication for that. And the second is for the comfort of the physician, to not have the government looking over your shoulder. Now, anytime you press send on a prescription, you can be worried that you're going to be second-guessed by the government. The searches of an individual's private life are repugnant not only to the way of life here, but violates the basic tenet of government sharing, government information sharing. If it is done for the sake of criminal prosecutions, for checking out whether there's criminal activity going on, and let's face it, these are just over-inclusive ways of attempts to give police more tools in its law enforcement efforts, then in our country, we need individualized suspicion before we need to submit to such searches. Dragnet searches for criminality have no place in our society in America. And taking a medication upon your doctor's advice is hardly criminal. I appreciate Mr. Long's comments, right? Mr. Long said, access to law enforcement will be extremely limited. And I take that to heart. But there are two things about that. The first, he did not disclaim that law enforcement will have access to it. He just said it will be extremely limited. And second, extremely limited access is not what we've seen in the states where this is played out. Databases are cross-shared. There's significant access by law enforcement authorities to these databases. And even if it's in current incarnation, and I know there's proposed legislation about this in Montana here, doesn't include that, you better believe that's going to be the next step. Now, some response, and one that's lacking, in my opinion, may be that we're not doing this as a law enforcement aid, but we're doing this to track what's going on in our communities. Now, that's a fair objective, in my opinion. And I think from a civil liberties perspective, if that's done right, there's nothing wrong with that. I think having more information is always a good thing. And I think we actually need a lot more good science, honest-based information about our drug policies. But maintaining these dragnet databases is not the way to do it. Well-done surveys can accomplish that same goal. The government all the time cites its Monitoring the Future study, and the government can take the significant amounts of money that it's going to devote to databases and do a good survey. And surveys don't suffer from the same problem of computer whizzes hacking into a database and stealing somebody's personal private medical information. This leads to a second concern, the prosecution of pain management doctors. It used to be that best practice standards were set by the AMA and state boards, not by the DEA. It used to be that the medical examining room was occupied by two people, and two people only, the patient and the physician. And now enter a third person, which is a federal agent. Now you'll hear a standard response from DEA. We prosecute very few doctors. And let me respond to that in two ways. First, I think the DEA is wrong about that. From 1999 to 2005, which are the most recent statistics that I was able to find, the DEA investigated more than 5,600 physicians for so-called and alleged drug diversion. And it prosecuted nearly 500 of them. The DEA will say, right, we didn't prosecute everybody we investigated. We actually prosecuted less than 10% of these of the physicians we investigated. But I don't need to explain to the people in this room that a visit from the DEA could be sufficient to ruin your practice. It's like the government investigating an individual, seizing every last penny of his or her assets, including his home and his car, under the asset forfeiture laws, not ultimately prosecuting the individual, and then saying, see, we have a heart. Go resume your lives. But irreparable damage has been done to the person whose assets have been seized, and irreparable damage has been done to the patients, to the physicians who've been investigated. There's a second problem with the DEA's inadequate response. Let's just take the DEA at its word that second-guessing 500 physicians through criminal prosecutions is insubstantial. These 500 prosecutions are enough to arouse quite a fear, and an understandable fear, I might add, among pain management specialists. The publication of those arrests sends a very clear message. We are watching you. And there, with that, they've accomplished their mission. There's a culture of fear that any particular pain management doctor may be next. And make no mistake, that's exactly what the DEA does. It arrests tens of thousands of people per year. And we hear only about 1% of those arrests. And yet, we hear basically about 100% of those arrests of pain management physicians. It highlights these arrests, talks about these arrests, makes it seem like it arrests thousands of doctors per year, when the real number is just a tiny fraction of that. But the damage is done. The chilling effect is very real. Nobody would want to give up their white jacket for the pinstripes of a prison uniform. And let me say that, where the real harm is done here, right? Because it's not just physicians, but it's all of those patients who want access to pain management, to pain medication, and who can't get it. Where you don't have pain management doctors in your area, where you have to travel hundreds of miles to find them. Or if there's one in your area, they say, I'm really worried about this, I can't do it anymore. The last thing I want to talk about, medical marijuana. You've certainly all heard about medical marijuana. And we've heard lots about the patient death, the deaths of patients from pain medications. Thousands of deaths per year, or something like this, tens of thousands of deaths per year. And I don't want to belittle that, but what I want to do is point out how many deaths we've had in the history of human existence from marijuana. And that number is 0. And yet, through recalcitrance of the federal government, which has put politics over science, it still refuses to recognize any medical benefits of cannabis. This despite the fact that nobody could seriously dispute the studies, which all show that marijuana can sharply reduce the pain and suffering of people afflicted with a host of illnesses. That's why numerous prominent national medical organizations, including the AMA, the American Academy of Family Physicians, the American Public Health Association, and many others, all have publicly adopted positions supporting medical marijuana. My purpose here, though, is not to talk about the benefits of medical marijuana, but rather to talk about what happens after the people have spoken, after initiatives have been passed, after legislatures have voted upon bills, saying, we don't want to prosecute sick and dying patients anymore, only because they're heeding their doctor's advice to try marijuana. What civil liberties issues arise after those laws have been passed, as it has been here in Montana? As an aside, Montana had the highest percentage of people voting in favor of the medical marijuana initiative, 62%. And for those who are not involved in political initiatives, I can tell you that's a huge number. It all boils down to this. Putting politics over science, the government continues an obstructionist policy that keeps people in constant pain, that attempts to enter the medical examining room, and that actively seeks to undermine the best medical judgment of physicians around the country. In 1996, after California passed its medical marijuana statute, numerous drug law enforcement related agencies of the federal government assembled in a room in Washington, D.C. And what was their goal? How do we stop this program? Well, they came up with an idea, which is that we cannot prosecute patients because that would be a PR hit for us, but we can prosecute physicians. And that's why my office, on behalf of numerous doctors, raised the First Amendment claim, raised the freedom of speech claim for doctors across the country, saying you have the right to talk about medical marijuana with your patients. As a matter of federal law, you don't have the right to prescribe it, but you have the right to talk about it. You have the right to recommend it. And all of the state medical marijuana laws are framed not in terms of prescriptions, but recommendations. And then what the patient does then, that's their business. But you've done your job in communicating to your patient what you think may be a good strategy to deal with his or her pain. Now, fortunately, the court agreed with us. The Court of Appeals of the Ninth Circuit, which covers Montana, held that doctors have a First Amendment right to recommend medical marijuana. So let me answer the question that was asked to Mr. Jaster here. Physicians should not be and cannot be investigated, let alone prosecuted, for recommending medical marijuana. I cannot say that any more clearly. There is a permanent injunction in place against the federal government. Permanent. It's not going to dissolve. It won't go away. It is there, and it's there to protect you. Why is this happening? Why is the DEA obstructing honest medical research? Why is the DEA invading people's medical privacy? The most common answer is that it's concerned with addiction. And let me say, I too am concerned with addiction. There's an addiction crisis in this country. That addiction is signaled by all the standard DSM-4 markers, right? Failure to fulfill major obligations, recurrent legal and social problems, etc. And while it's true that a number of Americans suffer from addiction to prescription medication, the addiction that I'm talking about is America's addiction. And that's America's addiction to harmful, counterproductive drug policies. The war on drugs, with its accompanying legal and social problems and threats to safety, has become America's drug of choice. And America needs an intervention before it's too late. We encounter the lives that have been unalterably damaged through lock-em-up policies, the children left without parents, physicians and other researchers who have been silenced, and still we're hooked. The criminal justice system has no role in treating addiction. It is doctors, it is treatment professionals, not DEA agents, who have the expertise to prescribe drugs, to monitor abuse, and for those developing addictions, to treat their patients with a medically sound regime. That regime does not involve paramilitary raids. That regime does not involve doling out 25-year prison sentences to physicians, treating them like corner drug dealers. It does not involve subpoenaing medical records of your patients, records that contain the most sensitive private medical information. We need a real, workable, sustainable strategy on drugs. A strategy that is based on science, based on research, based on reality and humanity. A strategy that recognizes that rational drug policy can be, must be, should be consistent with sound medical practice. A strategy that implores state boards to deal with doctors and the DEA to deal with corner drug dealers. A strategy where political agendas take a backseat to the dictates of science and the needs of patients. Thank you very much.
I think we'll wait to take questions and comments later. Okay, we're going to move on to the next panelist, who is Dr. Svoboda, who has 20 years of his 30 years as a physician blending addiction medicine expertise with family medicine. That's a terrific combination. We need more folks like that. For 15 of those 20 years, he's done teaching in Oregon, New Mexico, and Montana on the topic of prescription drug abuse. And I would say that when you first began to do that teaching, we really didn't have much of a problem. And now, as we've heard, it's really escalated.
I take full responsibility for closing the laptop and spilling water simultaneously, but they weren't related.
Go ahead.
Wow. It's easy to forget that I would suspect most of the people in this room have taken some kind of oath. An oath to relieve suffering and not contribute to harm, either personal or societal, in the process. It is a great pleasure to share a stage with Dr. Fishman. I love the word pharmacovigilance. It's sure a lot shorter and efficient than compassionate skepticism, which is the term I've been using. And in the defense of how I got mixed up with these folks, I'm not sure, but in their defense, I want to say that in the course of, and I've met both of these gentlemen before, Paul, I think I interviewed you by phone. And Mark, I'm actually a frustrated filmmaker and making a DVD, educational DVD training film for healthcare professionals on this topic. Should be completed this fall, I hope. And in that course of doing that, interviewed Mark. And when I was told I was going to be interviewing the chief narcotics officer for the state, I was prepared for a law enforcement perspective, and I got that. But it was spoken through the lips and the care of a public health officer. I really left that interview with the sense that the people who are out there carrying out and enforcing these laws were very concerned about the young people and the old people who were dying as a result of prescription drug abuse, mostly from accidental deaths. And I really do want to speak on their behalf. And I think what's really encouraging about this effort in this room is that people are coming together to create a balanced approach. It's like being part of a giant CQI project. And what we're looking for is a hemoglobin A1C to wrap our work around. And I'm here to tell you it does not exist. I did not hear it in Dr. Fishman's presentation. I missed most of yesterday, and I doubt if it occurred there. And I will tell you that my belief is that most of the issues that really grip prescribers, physicians, healthcare professionals in the area of prescription drug abuse are much less about the patients we're talking about, the drug-seeking patient. They're more about us and the system in which we practice and the culture in which we live, which is obsessed with altering consciousness, taking pills, quick fix. There are entire cultures which do not have back pain, where physical labor is far more strenuous than what we put ourselves through. The good news for me is I have the choice of hats to wear here. I can wear the hat of the only board-certified addictionist on the podium, as a PCP practicing in the trenches of Ennis, Montana, and believe me, prescription drug abuse is alive and well in rural Montana, or a frustrated filmmaker. The bad news is I have to condense 14 or 15 years of work in this area into 20 minutes. And I do believe I'll have a few minutes to spare. A few quick disclaimers. I'm not a pain expert, although when I mentioned to my colleagues at Kaiser Permanente in the Northwest region in Oregon back in the early 90s that I was interested in doing reviews of patients they were concerned about who might be abusing their pain medicines, I was flooded with referrals as a pain expert. And one of the first things I would tell people is, I am not a pain expert, I'm an addiction expert. I will tell you the vast majority of those people were undertreated, and the primary care physicians who did not like that recommendation, when I would inform them that there was no addictive process present, would say, well, would you just assume the management of these people? Because I don't feel comfortable prescribing this amount of medicine. And I would do that. And I wrote a poem, which I'll close with, which resulted from that effort. Because these people were challenging and difficult. We weren't talking about cancer pain, and I'm not really sure why it is we segregate cancer pain from non-malignant pain. But the idea of using opiates for non-malignant pain has been acceptable now for 10 to 20 years. It's been an accepted part of practice. why we would segregate people with cancer pain, even though a vast majority of them aren't necessarily dying of their cancer. The people I'm familiar with, working with in the field of addiction medicine, have cancer, and they have cancer of the spirit or the soul. And I look at it in very much an analogous way. I'm attempting to be unabashedly non-objective and personal here. In 1994, when I was working for Kaiser Permanente in the Northwest region, I spent 11 years there. And about midway through that 11-year stint was serving as a consultant, kind of working my way into the field of addiction medicine, blending it, integrating it with family practice, which is where I belong. Believe me, I don't see addicts under an addiction shingle. They turn the other way. The best place for me to be seeing them is integrated into a primary care practice. No self-respecting addict will go in to get a checkup on their addictive disease. And I really sincerely believe that. In '94, the researchers at the Center for Health Research in Portland, and at that time they had the largest database of patients, 400,000 patients, with all their clinical data had been entered into this giant computer that sat in the basement of an entire building, now could probably be compressed into this laptop. They realized there was a population of people who were problematic for our providers and for our healthcare system. And they actually reviewed all of the patients who had been prescribed opiates over a given 3 to 6 month period of time, subtracted those who had had surgery or an acute injury or cancer, which you were able to do because the diagnostic code was plugged in with the prescription. They came up with a population of people, there were about 400 of them, who had gotten opiates for one reason or another, where there weren't those 3 exclusionary factors. And they looked at the cost incurred by the healthcare system, Kaiser being interested in cost of care. The cost of care and the burden on our system of these opiate users, people who were using opiates, who, for the most part, probably received them for less than appropriate clinical reasons. And found their average age was in the 20s and 30s. These weren't old people. The cost and burden to the pharmacy system and the urgent care and ER system for these people was 5 times that of our Medicare Plus population. And they also recognized that these people had a huge amount of comorbidity in the mental health department. They also had a lot of traumas. These were people who we would call less than mindful. They were people who were, perhaps they were blurred, their judgment blurred because of the opiates, perhaps not, but they realized it was a burden financially. And at the same time, the Center for Recovery Resources, where I worked, surveyed all 800 healthcare providers who worked in the Northwest region at that time, mid-levels and PAs and nurse practitioners. What was the topic? We have money for a CME, an entire full-day conference. What was the topic they wanted to hear about? It wasn't detox, it wasn't nicotine, it wasn't the cost of alcoholism, it wasn't, doing methadone maintenance. It was dealing with the drug-seeking patient. And we put that term, and believe me, the worst drug-seeking patient I've ever encountered is a parent wanting an antibiotic for their child's respiratory infection. Seriously. Drug-seeking is a horrible pejorative term. So we decided to use it in our title, Serving and Surviving the Drug-Seeking Patient. The high point of that day was a panel after lunch. We did this one after lunch, and I got to be on the planning committee, so they let me steal the title for future reference. It was a panel of drug seekers, people who were in recovery or treatment, and they just talked about their experiences in doctors' offices. They were Seymour slack-jawed. There were 250 people who attended the conference. They were Seymour slack-jawed people who, when they were told, well, we know what you're going to do before we walk into your office, because we talked to our friends who went to your office, or and that the amount of sophistication has only improved. So I've been talking on this subject now for about 14 years. And just this year, put it on a PowerPoint. The copy of it is in your handout. So in '95, the state of Oregon, through the Center for Medical Excellence, Foundation for Medical Excellence, conducted an international conference on the topic of relief of suffering with controlled substances. And it was during that conference where it was alleged that we as a country were the stingiest prescribers in the developed world, milligram per capita. And we have corrected that. The people who manufacture drugs have heard that loud and clear, in the pain industry and the addiction industry have worked at times in opposite directions until 2004 around that issue. In 2004, the Association of Addiction Medicine, American Society of Addiction Medicine, and the American Pain Society made a joint statement, which is also included in your handout. And that was really the first time that the two industries began to work together. And it really was the first time we've started tracking effectively prescription drug abuse facts. What I can tell you is that the rate of increase for self-reported prescription drug abuse is 7 times that of our population growth. That it's implicated in 30% of ER mortality and morbidity. That in 2003, the number of emergency room visits which were associated to the abuse or misuse or accidental overdose or ingestion of prescription drugs exceeded the number of visits for illicit drug use. And those two curves have continued to diverge. In terms of young people, and there are a lot of people in the addiction field who really believe that addiction is a pediatric disease. And I think I'm coming to believe that probably is correct. Given the genetic information we have about substance abuse and the growing body of knowledge about opiate receptors, endorphins, that addiction is actually a pediatric illness. Now, 70% of our teenagers are getting their opiates from the medicine cabinet or from friends and family. They're not getting them from street vendors. And a large portion of those who are getting them off of the internet are getting counterfeit counterfeit medicines, because about half, I hope you may know if my sources are right or wrong, but I believe about half of the internet sales are counterfeit or come from international sources, and that a large number of those are actually counterfeit. So if you're struggling in an ER with somebody who said they had obtained over the internet a bunch of OxyContins and they're not responding to Narcan, wonder if maybe dextromethorphan and Benadryl were combined in large doses, and that's what your patient actually ingested. I really like that Scott used the word universal precautions. That's a term I could wrap myself around. And the first time I heard it was in 2004, when it was the first and only pain and addiction conference I've ever attended in Washington, D.C. And again, that was the year the two industries began to work side by side to come up with some rational strategies around this issue. David Gorley, I believe from Canada, I'm not sure exactly, used the term, and he had, I think, 6 highlights or bullet points in his presentation, and I've expanded it a bit. Just a few hints. Become comfortable witnessing witnessed or even unwitnessed urines, and where I learned how to do that really comfortably was, for 4 years, I was the medical director of New Mexico's Impaired Health Professional Program, so doctors and nurses and pharmacists, which is where I learned most of what I learned about addiction, was working with people like you in the Impaired Health Professional Program, where our real goal was to get people back into practice and And I learned a little bit about the psychology of the healer and what really gets physicians caught sometimes in this imperative to help people. And I got real comfortable, getting urines and doing it like I would do a finger stick UA. I'm not talking about forensically collectible urines. I'm talking about at the end of a 20-minute session or 15-minute session, handing a cup to somebody and walking across the bathroom and saying, well, I really want to trust what you're saying, and I was wondering if you would just prove that to me. It really helps in working with addicts to get down to their level, because addiction is a treatable disease, much like diabetes or cancer. And I said it before, that I think the issues that we're talking about here have as much to do with us as healers and how we respond to frustrating situations and deal with ambiguity and unknowns as it is about patients. I believe when the bumper Afghani opium crop hits here in a year or two, the issue of prescription opiate abuse will probably fade away. And when efforts like this roll out and become more effective, the prescription drug abuse will fade. But just to show you how this has touched me personally, I want to read a poem I wrote after I had volunteered to see all of these prescription drug abusing patients when I was working in Oregon. Your pain, your howling, screaming, grabbing, shooting, burning pain. I'm glad it's your pain. But sometimes when I'm vulnerable and maybe hurting a little bit myself, it becomes mine. And when the hurt becomes the center of your life for days, then months, then years, it is only some special conversion that will bring change. The pain won't come out of you, but you can come out of it. It haunts me, your pain. It's a stubborn, unending siege. The only way to win is to surrender. I beg all of you to keep improving your efforts. Please do not add another layer of a failed drug war. Thank you.
Thank you so much for that compassionate perspective.